Welcome. NSG 525. Study section 5. Severe burns. Introduction. There are times when people get injury on the skin due to it. This is called burn injury. In this study section, we will examine various types of burns and how to manage burn injury. Learning outcomes. When you have studied this section, you should be able to discuss the epidemiology of burns injury, discuss the prevention of severe burns injury, describe the anatomy and physiology of the integumentary system, list the type of burn injury, discuss the classification of severe burn injury, discuss the pathophysiology of burns, discuss the management of severe burn injury, enumerate the complications of burn injury. Epidemiology. Unintentional and intentional burn injuries vary across age groups, gender, income, and global region. An estimated 195,000 deaths every year are caused by burns. The vast majority occur in low and middle income countries. Non-fatal burns injury are leading cause of morbidity. Women in the WHO Southeast Asia region have the highest rate of burns, accounting for 27% of global burns deaths and nearly 70% of burn deaths in the region. Burns are among the leading causes of disability-adjusted life years lost in low and middle-income countries. In 2004, nearly 11 million people worldwide were burned severely enough to require medical attention. Some country data include, in India, over 1 million people are moderately or severely burnt every year. Nearly 172,000 Bangladeshi children are moderately or severely burnt every year. In Bangladesh, Colombia, Egypt, and Pakistan, 17% of children with burns have a temporary disability and 18% have a permanent disability. Burns are the second most common injury in rural Nepal, accounting for 5% of disabilities. In 2008, over 410,000 burn injuries occurred in the United States of America, with approximately 40,000 requiring hospitalization. According to the American Burn Association, an estimated 500,000 burn injuries receive medical treatment yearly in the United States. The 2009 National Burn Respiratory Report of most common cause of burns as direct fire or flame 43%, followed by scars 30%. Scar injuries were the predominant cause in children under the age of 5 and adults over 65. Burns sustained at home accounted for 65.5% of all burn injuries in the United States that year, and had a mortality rate of 4% overall. This mortality rate was directly associated with advancing age, burn size, the presence of inhalational injury, and female sex. It is estimated that approximately 75% of deaths from burns and fires in the United States occurs either at the scene of the incident or en route to medical facilities. Demographically, people sustaining burns in the United States tend to be male, 70%, to have suffered their injuries in a residential setting, 43%, with the highest incidence occurring in the 18 to 35-year-old age group. Locally, in a prospective study carried out by Asukwa, Ekpo, Nejim, and Agbo 2009 on burns trauma in adults at the University of Calabar Teaching Hospital, Calabar. Between a period of 3 years, it was found that burn injuries are among the most devastating injuries seen in the emergency units. 59 patients, 33 males and 26 females, accounted for 3.7% of trauma patients, and their age ranges from 15 to 70 years, mean 29.4 years. Flame burn was the commonest injury seen in 48, 81.3% patients due to petrol and kerosene, with chemical burn that involved 11.9% patients ranking second. Mobility included burns, wound infection in 13, 22% patients, and contraction in 6, 10.2% patients. The outcome was fatal in 15, 25.4% patients. According to Nambuko et al. 2007, in their 6 years retrospective review of burn injuries in Enugu. Burn injuries frequently occur in homes and workplaces and during travels. Flame burns accounted for 48.3% of burn injuries, followed by scarred with 40.6%. Chemical burns accounted for 6.3%, while electrical and friction burns accounted for 4.6% and 1% respectively. Males made up 60.4% of the cases and females 39.6%, ratio 1.5 to 1. The age group most commonly affected was the children aged between 0 to 10 years, accounting for 31.2% of cases, followed by the 21 to 30-year-old group with 22.7%. Altogether, 95.0% of the patients were aged less than 50 years. With regard to flame burns, 51.5% were due to petrol flames, premium motor spirits, while 33.0% were due to kerosene. Cooking gas explosions accounted for 7.5% of the cases, and diesel automotive gas oil 1%. Of discards, hot water accounted for 89.3% and oil to 7.7%. As to chemical burns, 84.6% were due to acid, with alkalis, corrosive creams, and other making up the rest. With regard to electrical injury, current passage accounted for 63.2% of cases and flash burns for 36.8%. Economic impact of burns. For 2000, direct costs for care of children with burns in United States of America exceeded $21 million. In Norway, costs for hospital burn management in 2007 exceeded €10.5 million. In South Africa, an estimated $26 billion is spent annually for care of burns from kerosene, paraffin, cook stove incidents. Indirect costs such as lost wages, prolonged care for deformities, and emotional trauma and commitment of family resources also contribute to the socio-economic impacts. People at risk. Gender. Females suffer burns more frequently than males. Women in the whole Southeast Asia region have the highest rate of burns, accounting for 27% of global burns deaths and nearly 70% of burn deaths in the region. Media Center 2014. The high risk for females is associated with open fire cooking or inherent unsafe cook stove, which can ignite lost clothing. Open flames used for eating and lighting also pose risk, and self-directed or interpersonal violence are also factors, although understudied. Age. Along with adult women, children are particularly vulnerable to burns. Burns are the 11th leading cause of death of children aged 1 to 9 years and are also of the 5th most common case of non-fatal childhood injuries. With 2014, why a major risk is improper adult supervision. A considerable number of burn injuries in children result from children maltreatment. Regional factors. There are important regional differences in burn rates. Infants in the WHO African region have 3 times the incidence of burn deaths than infants worldwide. Boys under 5 years of age living in low and middle economic income countries of the WHO Eastern Mediterranean region are almost twice as likely to die from burns as boys living in low and middle income countries of the WHO European region. The incidence of burn injuries required medical care is nearly 20 times higher in the WHO Western Pacific region than in the WHO region of the Americas. Socio-economic factor. People living in low and middle income countries are at higher risk for burns than people living in high economic countries. Within all countries, however, burn risk correlates with socio-economic status. Other risk factors. There are numbers of other risk factors for burns, including occupation that increase exposure to fire, poverty, overcrowding, and lack of proper safety measure, placement of young girls in household roles such as cooking and care of small children. Underlying medical conditions including epilepsy, peripheral neuropathic and physical and cognitive disabilities, alcohol abuse and smoking, easy access to chemical use for hazards such as in acid violence attacks, use of kerosene, paraffin as a fuel source for non-electric domestic appliances, inadequate safety measure for liquefied petroleum gas and electricity. Settings where burns can occur. Burns occur mainly in the home and workplace. Community surveys in Bangladesh and Ethiopia shows that 80 to 90% of burns occurs at home. Children and women are usually born in domestic kitchens from offset receptacles containing hot liquid or flames, or from cook stove explosion. They are most likely to be born in the workplace due to fire scars, chemical and electrical burns. Prevention of burns. As earlier noted, burns are preventable. High-income countries have made considerable progress in lowering rates of burn deaths through a combination of prevention strategies and improvement in the care of people affected by burns. Most of these advances in prevention and care have been incompletely applied in low and middle-income countries. Increased effort to do so will likely lead to significant reductions in rates of burn-related death and disability. Prevention strategies should address the hazard for specific burn injuries, education for vulnerable population, and training of communities in the first aid. An effective burn prevention plan should be multisectoral and include broad efforts to improve awareness, develop and enforce effective policy, describe burden and identify risk factors, search research priorities with promotion of promising intervention, provide burn prevention programs, strengthen burn care, strengthen capacities to carry out all of the above. There are numbers of specific recommendations for individuals, communities, and public health officials to reduce burn risk. Enclose fire and limit height of open flames in domestic environments. Promote several cook stoves and less hazardous falls, and educate regarding loose clothing. Apply safety regulations to housing designs and materials, and encourage home inspections. Improve the design of cook stove, particularly with regard to stability and prevention of access by children. Lower the temperature of hot water taps. Promote fire safety education and the use of smoke detectors, fire sprinklers, and fire escape systems in home. Promote the introduction of and compliance with industrial safety regulations and the use of fire retardant fabrics for children's sleepwear. Avoid smoking in bed and encourage the use of child-resistant lighters. Promote legislation mandating and production of fire-safe cigarettes. Improve treatment of epilepsy, particularly in developing countries. Encourage further development of burn care system, including training of healthcare providers in the appropriate triage and management of people with burns. Support the development and distribution of fire retardant aprons to be used while cooking around an open flame or kerosene stove. First aid treatment for burns. Stop the burning process by removing clothing and irrigating the burns. Use cool running water to reduce the temperature of the burn. Extinguish flames by allowing the patient to roll on the ground, or by applying a blanket, or by using water or other fire extinguishing liquids. In chemical burns, remove or dilute the chemical agent by irrigating with large volumes of water. Wrap the patient in a clean cloth or sheet and transport to the nearest appropriate facility for medical care. Do not start first aid before ensuring your own safety. Switch off electrical current, wear gloves for chemicals. Do not apply paste, oil, the turmeric, or raw cotton to the burn. Do not apply ice because it deepens the injury. Avoid prolonged cooling with water because it will lead to hypothermia. Do not open blister until topical antimicrobials can be applied, such as by healthcare provider. Do not apply any material directly to the wound as it might become infected. Avoid application of topical medication until the patient has been placed under appropriate medical care. Anatomy and physiology of the integumentary system. Being the largest human organ, the skin covers an area almost equivalent to 2 square meters and weigh between 7 to 10 kg. It serves as a protective barrier against the external environment while maintaining homeostasis internally. The skin is made up of two major layers, the epidermis and the dermis, which rest on the fatty layer called hypodermis. Subcutaneous tissue. Both epidermis and dermis are in turn composed of sublayers. The area that anchors the epidermis to the dermis is called the derma-epidermal junction. It is responsible for the exchange of oxygen, nutrients, and waste products between the vascularized dermis and the vascular epidermis. Epidermis. The epidermis is a multi-layered onyx-squamous epithelium that is usually between 0.03 and 0.05 millimeters thick and consists primarily of two cells which are keratinocytes. This divide in progressive stage of differentiation from deeper to more superficial layers. As keratinocytes divide, they move from the deeper layer to the more superficial layers. Once they reach the stratum corneum, the utmost layer, they are shared in the process of epidermal turnover, e.g. after bathing or scratching. This process is called desquamation. A complete epidermal turnover, skin renewal, takes approximately 2 months. Also found in the epidermis are the melanocytes. These cells produce melanin, which protects the skin from the harmful effects of ultraviolet radiation. They are also responsible for the skin pigmentation. Melanocytes are located in the basal layer of the epidermis as well as in ear follicle and in the eye. The layers of the epidermis are stratum corneum, only layer. It is the outermost layer of the skin and is made up of flattened, denucleated cells that are continuously shed. It serves as a barrier and storage system. Stratum lucidum, clear layer, consists of cells that refract a great deal of light. Stratum granulosum, granular layer, is made up of multiple layers of flattened cells with small nuclei. It contains epidermal lipid, waterproof barrier function. Stratum spinosum, prickle cell layer, is composed of multiple layers of polygonal cells responsible for strengthening of cells layers. Stratum basal cell layer of cylindrical cells which undergo cell division, mitosis. It contains melanocytes, eyes, skin, and ear pigmentation. Dermis. Compared to the thinner epidermis, the dermis is a complex network comprising cellular and acellular components. It contains blood vessels, nerves, ear roots, and sweat glands. Structurally, the dermis consists of two sublayers, the superficial papillary dermis and the deeper reticular dermis. The vascular loop of the papillary dermis supplies the epidermis with nutrients and oxygen. Collagen, mainly found in the reticular dermis. It is the major structural protein in the dermis, providing the skin with its durability. Elastin, another important structural protein in the dermis, gives the skin its elasticity. Fibroblasts are the principal cells of the dermis and are responsible for synthesis and degradation of the dermal proteins, collagen and elastin. Other cells found in the dermis, macrophages and lymphocytes. These cells are part of skin immune system. Hypodermis, subcutaneous tissue. The hypodermis forms the base for the epidermis and dermis and consists primarily of loose connective tissue and loops of fats. It contains larger blood vessels and nerves than those found in the dermis. The hypodermis serves mainly as an insulator and provides energy storage. Functions of the skin: protection against cold and heat, prevents mechanical impacts, prevents microorganisms from penetrating, destruction of inoculated microorganisms, reabsorption of specific substances, prevents excessive dehydration, which allowing a certain level of physiological water evaporation, permits vibration and tactile sensation. Social importance, appearance, and identification of a person. Protection, a protective barrier against the external environment such as chemical or mechanical injuries or ultraviolet radiation, and maintenance of a homeostasis internally. Sensation, sensitive to pain, touch, pressure, and temperature. Thermoregulation through dilation and constriction of vessels and sweating. Metabolism, synthesis of vitamin D, calcium and phosphate metabolism in the presence of sunlight. Types of burn. The main types of injury sources are thermal, chemical, electrical radiation, and smoke or inhalation injuries. Thermal injuries. Thermal burns are the most common cause of burns injuries and result from exposure to hot liquids, flame, and hot objects. Extreme cold can also produce a burn injury. The severity of injury is related to the temperature and duration of exposure or contact. Scarred burns. About 70% of burns injury are caused by scars. Most scarred burns injury occur in the kitchen or bathroom and involve hot water or liquids. The case fatality rate of scarred burn injury is generally low, presumably due to the limited extent and depth of the burn. But scars are major causes of morbidity and associated health care costs, particularly in children less than 5 years of age and in the elderly. Flame burns. Flame burns are common in the adolescents and adults. The misuse of force and flammable liquids is a major cause of injury. The injury is commonly associated with male peer group activities involving gasoline or other inflammable products, such as fireworks. As fires are also a significant cause of flame burn injury associated with the additional risk of inhalation injury. Flame is the predominant cause of burn in patients admitted to the burns unit, particularly in the adult age group. Contact burns. In order to sustain a contact burn, the object touched must either have been very hot or the contact was for a long period of time. Impaired consciousness due to misuse of alcohol or drugs is a common cause for a contact burn. Temperature of up to 45 degrees Celsius can be tolerated relatively for a long time without causing damage, whereas higher temperature results rapidly in a burn injury. As little as 10 seconds of exposure to water at 70% degrees can cause a full thickness burn in adults. It takes 7 shorter duration exposure to cause a deep burn in a child. Although contact burns are confined to the point of contact, they tend to be often very deep. Cold-induced injury, frostbite. Development of frostbite is strongly associated with ethanol consumption. Other well-recognized factors include homelessness, improper clothing, or high altitude. The duration and efficiency of tissue cooling have marked effects on the extent of cold injury. Frostbite injuries are caused by 2 mechanisms. The first is that of direct cellular damage, formation of ice crystals, and the second is the more delayed process mediated by progressive tissue ischemia. Patients sustain frostbite are at high risk for hypothermia. Chemical burns. Chemical burns are often smaller in area than thermal burns, but are more likely to be full thickness in depth as the corrosive agent continues to cause damage until completely removed. The severity of chemical burns is related to the agent of exposure, the duration of contact, and the agent's concentration. Volume and mechanism of action. The most common cause of chemical burns are alkalis and acids. Alkali are commonly found in industrial cleaners, drain cleaners, and cement. These agents damage tissue by colliquative necrosis, the generation of tissue to a liquid state, and protein denaturation, which allows for deeper spread of the chemical into tissues and a more severe injury. Acid may be found in bathroom cleaners, rust removers, and industrial drain cleaners. Acidic agents damage tissue by coagulation, necrosis, and protein precipitation, which usually limits the depth and spread of tissue damage. The initial management of all chemical burns is the same regardless of the causative agent. All contaminated clothing must be removed and the area should be thoroughly irrigated, which is the best achieved by showering the patient as soon as possible. This has been shown to limit the depth of the burn. Note: eye injuries should be irrigated copiously. An ophthalmologist. Electrical burns. Electrical burns result from an electrical current flowing through the body from one point to another, creating entry and exit points and damaging the tissue between these 2 points. The damage of the electrical current to the body is determined by the following factors: type of current, alternating or direct, amount of current, pathway of current, duration of contact, area of contact, and resistance of the body, and voltage. Voltage is the main determinant of the degree of tissue damage. Therefore, electrical injuries are divided into these caused by low voltage, less than 1000 volts, and those due to high voltage current, 1000 volts or higher. Low voltage, e.g. domestic current, tend to cause small, deep contact burns at the exit and entry sites. However, they can interfere with the cardiac cycle and give rise to arrhythmias with potential lethal outcomes. High voltage burns commonly cause extensive tissue damage. There is usually a large amount of soft and bony tissue necrosis, which also leads to limb loss. Muscle damage gives rise to rhabdomyolysis, rapid breakdown of muscle tissue resulting in renal failure. This injury pattern needs more aggressive resuscitation and debridement than other burns. Early operation in patients with electrical burn is recommended, as massive deep tissue necrosis can lead to severe acidosis and tissue swelling, which in turn increases the risk of compartment syndrome, elevation of tissue pressure with vascular compromise. The highest incidence of electrical injuries is work-related, construction workers, utility and electricity worker, and high voltage, with primary victims being young men. Smoke and inhalation injuries. Inhalation injury is the most frequent accompanying condition associated with burns. Fires usually emit smoke, which victim may inhale, especially in closed spaces such as in house fires. There are 3 types of smoke and inhalation injuries: carbon monoxide poisoning, inhalation and injuries above the glottis to the upper airway, inhalation injuries below the glottis to the lower airway. Carbon monoxide CO2 poisoning is the most common type of fatal poisoning. CO binds to hemoglobin with an affinity 200 times greater than oxygen. When sufficient hemoglobin is bound to CO, tissue hypoxia occurs, with the most immediate threat to hypoxia-sensitive tissues such as the brain. Clinically, patients may have clear cherry red coloration. Neurologic dysfunction is common, progressing from headache to coma. Early administration of 100% oxygen should be initiated as soon as possible. Upper airway injuries are usually heat-related, and tissue damage occurs above the level of the glottis. As with other burn injury, tissue edema can develop very rapidly and cause airway obstruction. Intubation with mechanical ventilation may be necessary to provide adequate oxygenation until the edema resolves. Lower airway injuries are chemical in nature and are related to the inhalation of nauseous chemicals that are products of combustion. Suspicion may be raised with history of flame-related injury in an enclosed space or loss of consciousness at the scene. Clinical manifestation can be delayed from 1 to 3 days after exposure, as the mucosal slurs and secretion accumulate to obstruct the airway and cause atelectasis. Classifications of burn injury. Burn injury are related to severity of injury, which is determined by 1. Depth of burn. 2. Extent of burn calculated in percent of total body surface area. 3. Location of the burn. 4. Patient risk factors. This classification will determine if the patient meets referral criteria to a specialized burns unit as recommended by the American Burn Association. ABA. Lewis et al. 2007. For an in-depth understanding of the classification of burns, especially according to depth, it is important to review the anatomy of the skin. Being the largest human organ, the skin covers an area almost equivalent to 2 square meters and weigh between 7 to 10 kg. It serves as a protective barrier against the external environment while maintaining homeostasis internally. The skin is made up of 2 major layers, the epidermis and the dermis, which rest on a fatty layer called hypodermis. Subcutaneous tissue, both epidermis and dermis, are in turn composed of sublayers. The area that anchors the epidermis to the dermis is called the derma-epidermal junction. It is responsible for the exchange of oxygen, nutrients, and waste products between the vascularized dermis and the avascular epidermis. Classification according to the depth of burn. The depth of burn wound depends on the temperature and the duration of contact with the injury agents, as well as the thickness of the skin and blood supply to the injury area. Burn depth is described as follows, going from the most superficial to the deepest. Superficial burns. The type of burns involve only the epidermis. They are red, dry, and painful, blanched, and are tender to palpation. The injured epidermis lost within a few days. They require only symptomatic care and usually see within 1 week without scarring. There is no blistering, and healing usually takes place after several days without scarring. Because the epidermal barrier remains intact, systemic response and risk of infection are minimal. Most common causes of superficial burns are severe sunburns. Superficial partial thickness burn. This involves the epidermis and superficial papillary dermis and usually forms blister. However, blistering may not occur immediately following injury, and burns thought to be superficial may subsequently be diagnosed as superficial partial thickness burns. Once the blisters are removed, the burn appear pink and moist. Characteristically, these burns are exquisitely tender when touched. With appropriate wound care, superficial partial thickness burns usually heal spontaneously in approximately 2 to 3 weeks without the risk of scarring and therefore do not require surgical attention. Deep partial thickness burns. Thick partial thickness burns extend into the reticular dermis. The skin color in this burn is usually a mixture of red and blanched white. The wound is often less sensitive to pinprick than the surrounding skin. The injured tissue may heal spontaneously in 3 to 4 weeks if no infection arises by epithelialization from the few viable epithelial appendages at this deepest layer of dermis. However, deep partial thickness burns are predicted not to heal by 3 weeks, which usually require excision and grafting, because these burns have less capacity for re-epithelializing. A greater potential for hypertrophic scar formation exists. Contraction across joints with resulting limitation in range of motion is a common complication. Foot thickness burns. This type of burns involve the entire epidermis and dermis and may extend into subcutaneous tissue, muscle, and bone. The capillary network of the dermis is completely destroyed and the wound has a charred, white, or leathery appearance due to destroyed collagen, are variable in color depending on the causative agent, are insensate due to destruction of sensory nerve endings, and unless they are very small, do not heal spontaneously. They may require amputation or complex reconstruction such as excision and grafting in order to expedite the patient's recovery process and prevent infection and hypertrophic scarring. Immersion scars, flame burns, and chemical and high voltage electrical injuries are common cause of full thickness burns. Many burns wounds are mixture of bone depth. So patients with full thickness burns frequently also have painful partial thickness burns, need treatment for pain as well. Classification according to extent of total body surface area. Proper calculation of the burn extent is highly important for treatment and transfer decisions. There are 3 methods to assess the burn wound size: rule of nines and the long boundary chart, the Palmer method. The rule of nines is commonly used in the pre-hospital setting because it is easy to remember and use. It divides the adult body into anatomical regions of 9% or a multiple of 9%. Infants and small children have larger heads and smaller legs than adults, and so the rule is modified for them by doubling the size of the head from 9% to 18% and decreasing each leg from 80% to 14%. The Lombard chart is the preferred method as it is the most accurate for patients of all ages. The burn area is identified as partial or full thickness burn and the extent is drawn on a carton figure. The total body surface area involved can then be calculated by using an associated age-specific table, which is completed at admission to determine fluid requirements and repeated after 72 hours to recalculate the burn area which may have extended. Palmer method. With scattered small burns, such as splash burns from spill hot liquid. This is the most applicable method. Here, the patient's palm, including the fingers, which represents approximately 1% of the area of burns covered, is used. Classification according to location of burn. The location of burn injury is highly important when assessing the burn wound because skin varies in thickness, the amount of subcutaneous fat, and the number of blood vessels from one location in the body to another. Upper airway obstruction can be caused by edema produced from burns of the oropharynx or fluid shift into soft tissue of the upper airway, resulting from the burns of the face and or neck. Likewise, burns of the hands, feet, or those involving the perineum may severely limit an individual's autonomy. Because of fluid shift into tissue beneath, a burn patient with circumferential burns of an extremity are in danger of developing ischemia of underlying and distal tissue from decreased tissue pressure compartment syndrome. Therefore, close monitoring of patients with burns to the face, neck, and feet and perineum, as well as circumferential burns to extremities and chest, is recommended, and admission to a burn unit should be considered. Classification according to patient risk factor. Age. Patients between 5 and 20 years of age have the most favorable survival outcome from burns. The LA 50% of total body surface area at which 50% of the patients live and 50% die. For this age group is 94.5%. TBSA of burn. Take 2. 94.5% TBSA of burn. Younger individuals and elderly people are at higher risk of morbidity as well as mortality from a burn injury. This is due to the fact that they have thinner skins, which results in deeper burns. In addition, older people have commonly premorbid diseases. For example, any patient over the age of 70 years with burn is in danger regardless of the extent of the burn. The LA50 for this age group is 29.5% TBSA. Premorbid diseases. Premorbid diseases often have a significant influence on the clinical outcome of a burn injury. Medical conditions that are known to exacerbate the morbidity of patients with burn include renal failure, cardiac insufficiency, hypertension, chronic obstructive pulmonary disease, diabetes, morbid obesity, and other diseases which compromise the immune system. The clinical status of any of these disorders must be carefully assessed and their potential influence on the outcome determined before making any decision whether the patient can be safely managed as an outpatient. Local response to burn injury. The local response to a burn injury is best described with the Jaskin burn wound model. The burn is categorized by three concentric zones of tissue injury: zone of coagulation, zone of stasis, and zone of hyperemia. The zone of coagulation is at the center of the burn wound where no viable cells remain. The surrounding zone of stasis is characterized by decreased tissue perfusion and a mix of viable and non-viable cells. These cells are, however, highly sensitive at an increased risk for necrosis over the next few hours or days because of the inflammatory response release of vasoactive mediators and resultant edema, ischemia, cellular dehydration, and infection. However, with proper wound management, these changes may be reserved. Factors such as advance in age or diabetes put the zone of stasis at high risk for wound conservation. The main aim of burns resuscitation is to increase tissue perfusion here and prevent any damage becoming irreversible. In the zone of hyperemia, which is utmost zone, tissue perfusion is increased due to vasodilation by inflammatory mediators. This tissue in this zone usually recover unless there is severe sepsis or prolonged hypoperfusion. 5. Pathophysiology of burns. Burns are caused by a transfer of energy from heat source to the body. It may be transferred through conduction or electromagnetic radiation. Burns are categorized as thermal, which includes electrical burns, radiation, or chemical. Tissue destruction results from coagulation, protein denaturation, or ionization of cellular contents. The skin and the mucosa of the upper airways are the sites of tissue destruction. Deep tissue, including viscera, can be damaged by electrical burns or through prolonged contact with a heat source. Disruption of the skin can lead to decreased fluid loss, infection, hypothermia, scarring, and compromised immunity, and changes in function, appearances, and body image. The depth of the injury depends on the agent. For example, in the case of scarred burns in adults, 1 second of contact with hot tap water at 68.9 degrees Celsius, 156 degrees Fahrenheit, may result in a burn that destroys both the epidermis and the dermis, causing a full thickness, 3rd degree injury. 15 seconds of exposure to hot water at 56.1 degrees Celsius, 133 degrees Fahrenheit results in a similar full thickness injury. Temperatures less than 111 degrees Fahrenheit are tolerated for long periods without injury. Local and systematic responses to injury. Burn types could be thermal, chemical, or electrical burns. Burns that do not exceed 25% TBSA produce a primarily local response. Burns that exceed 25% TBSA may produce both a local and a systemic response and are considered major burn injury. This systemic response is due to the release of cytokines and other mediators into the systemic circulation. The release of local mediators and changes in blood flow, tissue edema, and infection can cause progression of the burn injury. Pathophysiologic changes resulting from major burns during the initial burn stock period include tissue hypoperfusion and organ hypofunction, secondary to decreased cardiac output, followed by hyperdynamic and hypermetabolic phase. The incidence, magnitude, and duration of pathophysiologic changes in burns are proportional to the extent of burn injury, with a maximum response seen in burns covering 60% or more TBSA. The initial systematic event from a major burn injury is hemodynamic instability, resulting from loss of capillary integrity and a subsequent shift of fluid, sodium, and protein from the intravascular space into the interstitial space. Hemodynamic instability involves cardiovascular, fluid and electrolytes, blood volume, pulmonary, and other mechanisms. Cardiovascular response. Hypovolemia is the immediate consequence of fluid loss resulting in decreased perfusion and oxygen delivery. Cardiac output decreases before any significant change in blood volume is evident. As fluid loss continues and vascular volume decreases, cardiac output continues to fall and blood pressure drops. This is the onset of burn shock. In response, the sympathetic nerve system increases catecholamines, resulting in an increase in peripheral resistance vasoconstriction and an increase in pulse rate. Peripheral vasoconstriction further decreases cardiac output. Myocardial contractility may be suppressed by the release of inflammatory cytokine necrosis factor. Prompt fluid resuscitation maintains the blood pressure in the low normal range and improves cardiac output. Despite adequate fluid resuscitation, cardiac filling pressures, central venous pressure, pulmonary artery pressure, and pulmonary artery wedge pressure remain low during the burn shock period. If inadequate fluid resuscitation occurs, distributive shock will occur. Generally, the greatest volume of fluid leak occurs in the first 24 to 36 hours after the burn, peaking by 6 to 8 hours. As the capillaries begin to regain their integrity, burn shock resolves and fluid returns to the vascular compartment as the fluid is reabsorbed from the interstitial tissue into the vascular compartment. Blood volume increases. If renal and cardiac function is inadequate urinary output increases. Diuresis continue for several days to 2 weeks. Bone edema. Local swelling due to thermal injury is often extensive. Edema is defined as the presence of excessive fluid in the tissue spaces. As previously noted, in burns involving less than 25% TBSA, the loss of capillary integrity and shift of fluid are localized to the burn itself, resulting in blister formation and edema only in the area of injury. Patients with more severe burns develop massive systematic edema. Edema is usually maxima after 24 hours. It begins to resolve 1 to 2 days post-burn and usually is completely resolved in 7 to 10 days post-injury. Edema in burn wounds can be reduced by avoiding excessive fluid during the early post-burn period. Unnecessary over-resuscitation will increase edema formation in both burn tissue and non-burn tissue. As edema increases in circumferential burns, pressure on small blood vessels and nerves in the distal extremities causes an obstruction of blood flow and consequent ischemia. This complication is known as compartment syndrome. The physician may need to perform an echotomy, a surgical incision into the eschar, devitalized tissue resulting from a burn, to relieve the constricting effects of the burn tissue. Effects on fluids, electrolytes, and blood volume. Circulatory blood volume decreases dramatically during burn shock. In addition, evaporative fluid loss through the burn wound may reach 3 to 5 L or more over a 24-hour period until the burn surface are covered. During burn shock, serum sodium levels vary in response to fluid resuscitation. Usually, hyponatremia, sodium depletion is present. Hyponatremia is also common during the first week of the acute phase as water shifts from the interstitial to the vascular space. Immediately after burn injury, hypokalemia, excessive potassium results from massive self-destruction. Hypokalemic potassium depletion may occur later with fluid shifts and inadequate potassium replacement. At the time of burn injury, some red blood cells may be destroyed and others damaged, resulting in anemia. Despite this, the hematocrit may be elevated due to plasma loss. Blood loss during surgical procedures, wound care, and diagnostic studies and ongoing hemolysis further contribute to anemia. Blood transfusions are required periodically to maintain adequate hemoglobin levels for oxygen delivery. Abnormalities in coagulation, including a decrease in platelets, thrombocytopenia, and prolonged clotting and prothrombin time, also occur with burn injury. Pulmonary response. Inhalation injury is the leading cause of death in fire victims. It is estimated that half of these deaths should have been prevented with the use of smoke detector. Inhalation injury has a significant impact on survivability of a burn patient. Deterioration in severely burned patients can occur without evidence of a smoke inhalation injury. Bronchoconstriction caused by release of histamine, serotonin, and thrombozone, a powerful vasoconstrictor, as well as a chest constriction secondary to circumferential foot thickness. Chest burn cause this deterioration. 1/3 of all burn patients have a pulmonary problem related to the burn injury. Even without pulmonary injury, hypoxia, oxygen starvation may be present. Early in the post-burn period, catecholamine release in response to the stress of the burn injury alters peripheral blood flow, thereby reducing oxygen delivery to the periphery. Later, hypermetabolism and continued catecholamine release lead to increased tissue oxygen consumption, which can lead to hypoxia. To ensure that adequate oxygen is available to the tissues, supplemental oxygen may be needed. Pulmonary injuries fall into several categories: upper airway injury, inhalation injury between glottis, including carbon monoxide poisoning and restrictive defects. Upper highway injury results from direct hit or edema. It is manifested by mechanical obstruction of the upper airway, including the pharynx and the larynx. Because of the cooling effects of rapid vaporization in the pulmonary tree, direct heat injury does not normally occur below the level of the bronchus. Upper airway injury is treated by early nasotracheal or endotracheal intubation. Inhalation injury below the glottis results from inhaling the products of incomplete combustion or nauseous gases. These products include carbon monoxide, sulfur oxide, nitrogen oxide, aldehydes, cyanide, ammonia, chlorine, phosgene, benzene, and halogens. The injury results directly from chemical irritation of the pulmonary disease at the alveolar level. Inhalation injuries below the glottis cause loss of ciliary action, hypersecretion, severe mucosal edema, and possibly bronchospasm. The pulmonary surfactant is reduced, resulting in atelectasis, collapse of the alveoli. Expectoration of carbon particles in the sputum is the cardinal sign of this injury. Carbon monoxide is probably the most common cause of inhalation injury because it is byproduct of the combustion of organic materials that is therefore present in smoke. The pathophysiologic effects are due to tissue hypoxia, a result of carbon monoxide combining with hemoglobin to form carboxyhemoglobin, which competes with oxygen for available hemoglobin binding sites. The affinity of hemoglobin for carbon monoxide is 200 times greater than that for oxygen. The treatment usually consists of early intubation and mechanical ventilation with 100% oxygen. However, some patients may require only oxygen therapy depending on the extent of pulmonary injury and edema. Administering 100% oxygen is essential to accelerate the removal of carbon monoxide from the hemoglobin molecule. Restriction defects arise when edema develops under full thickness bonds encircling the neck and thorax. Chest excursion may be greatly restricted, resulting in decreased tidal volume. In such situation, escharotomy is necessary. Pulmonary abnormalities are not always immediately apparent. More than half of all burns victims with pulmonary involvement do not initially demonstrate pulmonary signs and symptoms. Any patient with possible inhalation injury must be observed for at least 24 hours for respiratory complications. Airway obstruction may occur very rapidly or develop in hours. Decreased lung compliances, decreased arterial oxygen levels, and respiratory acidosis may occur gradually over the first 5 days after a burn. Indicators of possible pulmonary damage include the following: history indicating that the burn occurred in an enclosed area, burns of the face or neck, single nasal air, singe. Take 2, singed nasal air, ONS, voice change, dry cough, stridor, sooty sputum, blood sputum, labored breathing or trachopnea, rapid breathing, and other signs of reduced oxygen levels, hypoxemia. Erythema and blistering of the oral or pharyngeal mucosa. A diagnosis of inhalation injury is an important priority for many burn victims. Serum carboxyhemoglobin levels and arterial blood gas levels are frequent use to assesses for inhalation injury scans can also be used to aid diagnosis in the early post-burn period. Pulmonary function studies may also be used in diagnosing decreased lung compliances or obstructed airflow. Pulmonary complications secondary to inhalation injuries include acute respiratory failure and acute respiratory distress syndrome. Respiratory failure occurs when impairment of ventilation and gas exchange of life-threatening. The immediate intervention is intubation and mechanical ventilation. If ventilation is impaired by restricted chest excursion, immediate chest escharotomy is needed. ARDS may develop in the first few days after the burn injury secondary to systemic and pulmonary response to the burn and inhalation injury. Other systemic responses. Renal function may be altered as a result of decreased blood volume. Destruction of red blood cells at the injury site results in free hemoglobin in the urine. If muscle damage occurs, e.g. from electrical burns, myoglobin is released from the muscle cells and excreted by the kidneys. Adequate fluid volume replacement restores renal blood flow, increasing the glomerular filtration rate and urine volume. If there is inadequate blood flow through the kidneys, the hemoglobin and myoglobin occlude the renal tubules, resulting in acute tubular necrosis and renal failure. The immunologic defenses of the body are greatly altered by burn injury. Serious burn injury diminishes resistance to infection. As a result, sepsis remains the leading cause of death in thermally injured patients. The loss of skin's integrity is compounded by the release of abnormal inflammatory factors, altered levels of immunoglobulins and serum complements, impaired neutrophil function, and a reduction in lymphocytes. Lymphocytopenia. Research suggests that burn injury results in loss of T helper cell lymphocytes. There is a significant impairment of the production and release of granulocytes and macrophages from bone marrow after burn injury. The resulting immunosuppression places the burn patients at high risk for sepsis. Loss of skin also results in inability to regulate body temperature. Burn patients may therefore exhibit low body temperature in the early hours after injury. Then, as hypermetabolism resets core temperatures, burn patients become hyperthermic for much of the post-burn period, even in the absence of infection. Two potential gastrointestinal complications may occur: paralytic ileus, absence of intestinal peristalsis, and Collins ulcer. Decreased peristalsis and bowel sound are manifestations of paralytic ileus resulting from burn trauma. Gastric distension and Gastric distension and nausea may lead to vomiting unless gastric decompression is initiated. Gastric bleeding secondary to massive physiologic stress may be signaled by occult blood in the stool. Regurgitation of coffee ground, material from the stomach, or bloody vomiters. These signs suggest gastric or duodenal erosion. Collins ulcer. 6. Management of severe burn injury. Medical management of severe burn injury. Burn care must be planned according to the burn depth and local response, the extent of the injury, and the presence of a systemic response. Burn care then proceeds through 3 phases: emergent or resuscitative phase, acute or intermediate phase, rehabilitation phase. Although priorities exist for each of the phases, the phase overlap and assessment and management of specific problems and complications are not limited to these phases, but take place throughout burn care. Emergent or resuscitative phase of burn care. On the same care, anyone who encounters a burn victim for the first time may feel overwhelmed. The burn person's appearance can be frightening at first. It can be difficult not to get caught up with the appearance of the person and instead to concentrate on the burn wound. However, the burn wound is not the first priority at the scene. The first priority of the on-scene care for burn victim is to prevent injury to the rescuer. If needed, fire and emergency medical service should be requested at the first opportunity. Airway, breathing, circulation. Although the local effects of a burn are the most evident, the systemic effect pose a greater threat to life. Therefore, it is important to remember the ABCs of all trauma care during the early post-burn period: airway, breathing, circulation. Cervical spine immobilization for patients with high voltage electrical injuries, and if indicated for other injuries, cardiac monitoring for patients with all electrical injuries for at least 24 hours after cessation of of dysrhythmia. Some practitioners include DEF in the trauma assessment, disability exposure, and fluid resuscitation. The circulatory system must also be assessed quickly. Apical pulse and blood pressure are monitored frequently. Tachycardia, abnormally rapid heart rate, and slight hypotension are expected soon after the burn. The neurologic status is assessed quickly in the patient and extensive burn. Often the burn patient is awake and alert initially, and vital information can be obtained at that time. A secondary head-to-toe survey of the patient is carried out to identify other potentially life-threatening injuries. The E and F parameters of trauma assessment are discussed in detail later. Preventing shock in a burn patient is imperative. Usually, rescue workers will cool the wound, establish an highway, supply oxygen, and insert at least one large bore intravenous line. Emergency medical management. The patient is transported to the nearest emergency department, the hospital, and physician alerted that the patient is en route to the emergency department so that life-saving measures can be initiated immediately by a trained team. Initial priorities in the emergency department remain highway, breathing, and circulation. For mild pulmonary injury, inspired air is humidified and the patient is encouraged to cough so that secretions can be removed by suctioning. For more severe situations, it is necessary to remove secretions by bronchial suctioning and to administer bronchodilators and mucolytic agents. If edema of the airway develops, endotracheal intubation may be necessary. Continuous positive airway pressure and mechanical ventilation may also be required to achieve adequate oxygenation. After adequate respiration status and circulatory status have been established, the patient is assessed for cervical spinal injuries. For cervical spinal injuries or head injury, if the patient was involved in an explosion, a fall, a jump, or an electrical injury. Once the patient's condition is stable, attention is directed to the burn wound itself. All clothing and jewelry are removed. For chemical burns, flushing of the exposed area is continued. The patient is checked for contact lenses. These are removed immediately if chemicals have contacted the eyes or if facial burns have occurred. It is important to validate an account of the burn scenario provided by the patient, witnesses at the scene, paramedics. Information needs to include time of the burn injury, source of the burn, place where the burn occurred, how the burn was treated at the scene, and any history of falling with the injury. A history of pre-existing diseases, allergies, and medication, and the use of drugs, alcohol, tobacco is obtained at this point to plan care. A large bore 16 or 18 gauge intravenous catheter should be inserted in non-burn area. If not inserted earlier, most patients have a central venous catheter inserted so that large amounts of intravenous fluids can be given quickly and central venous pressures can be monitored. If the burn exceeds 25% TBSA or if the patient is nauseated, or a nasogastric tube should be inserted and connected to suction to prevent vomiting due to paralytic ileus absence of peristalsis. The physician evaluates the patient's general condition, assesses the burn, determines the priorities of the care, and directs the individualized plan of a treatment, which is divided into systemic management and local care of burned area. Non-sterile gloves, caps, and gowns are worn by personnel while assessing the exposed burn area. Clean technique is maintained while assessing burn wounds. Assessment of both the TBSA burn and the depth of the burn is completed after shots and debris have been gently cleansed from the burn wound. Careful attention is paid to keeping the burn patient warm during wound assessment and cleansing. Assessment is repeated frequently throughout burn wound care. Photographs may be taken of the burn areas initially and periodically throughout treatment. In this way, the initial injury and burn wound can be documented. Such documentation is invaluable for insurance and legal claims. Clean sheets are placed under and over the patient to protect the area from contamination, maintain body temperature, and reduce pain caused by air currents passing over exposed nerves ending. An indwelling catheter is inserted to permit more accurate monitoring of urine output and renal function for patients with moderate to severe burns. Baseline height, weight, arterial blood gases, hematocrits, electrolytes, values, blood alcohol level, drug panel, urinalysis, and chest X-ray are obtained. If the patient is elderly or has an electrical burn, a baseline electrocardiogram is obtained. Because burns are contaminated wounds, tetanus prophylaxis is administered if the patient's immunization status is not current or is unknown. Only intravenous pain medication, usually morphine, is given, titrated for the patient. If the patient wishes to see a spiritual advisor, one is notified. Transferred to a burn center. The depth and extent of the burn are considered in determining whether the patient should be transferred to a burn center. Burn injury patients who should refer to a burn unit include following: all burn patients less than 1 year of age, all burn patients from 1 to 2 years of age with burns less than 5% total body surface area, patients in any age group with third-degree burns of any size, patients older than 2 years with partial thickness burns greater than 10% TBSA, patients with burns of special areas, face, hands, feet, genitalia, perineum, and major joints, patients with electrical burns including lightning burns, chemical burns patients with inhalation injury resulting from fire or scarred burns, patients with circumferential burns of the limbs or chest. Burns injury patients with pre-existing medical disorders that could complicate management, prolong recovery, or affect mortality. Any patient with burns and concomitant trauma, pediatric burn cases where child abuse is suspected. Burn patients with treatment requirements exceeding the capabilities of the referring center, septic burn wound cases. Patients with major burns, those who are at the extremes of age continuum, those with coexisting health problems that may affect recovery, and those with circumstances that increase the risk for acute and long-term complications are transferred to a burn center. If the patient is to be transported to a burn center, the following measures are instituted before transfer. A secure intravenous catheter is inserted with lactated Ringer's solution, infusing at the rate required to maintain a urine output of at least 10 milliliters per hour. A patient's airway is ensured. Adequate pain relief is attained. Adequate peripheral circulation is established in any burn extremity. Wounds are covered with a clean, dry sheet, and the patient is kept comfortably warm. All assessments and treatments are documented, and the information is provided to the burn center personnel. The transferring facility must rely accurate intake and output totals to burn center personnel so that adequate fluid resuscitation measures continue. Management of fluid loss and shock. Next to handling respiration difficulties, the most urgent need is preventing irreversible shock by replacing lost fluids and electrolytes. As mentioned previously, survival of burn victim depends on adequate fluid resuscitation. Table 57-3 summarizes the fluid and electrolyte changes in the emergent phase of burn care. Intravenous lines and an indwelling catheter must be in place before implementing fluid resuscitation. Baseline weights and laboratory tests results are obtained as well. This parameter must be monitored closely in the immediate post-burn resuscitation period. Controversy continues regarding the definition of adequate resuscitation and the optimal fluid type for resuscitation. Refinement of resuscitation techniques remain an active area of burn research. fluid replacement therapy. The total volume and rate of intravenous fluid replacement are gauged by patient response. The adequacy of fluid resuscitation is determined by following urine output totals and index of renal perfusion. Output totals of 30 to 50 milliliter per hour have been used as goals. Other indicators of adequate fluid replacement are a systolic blood pressure exceeding 100 mmHg and or a pulse rate less than 110 per minute. Guidelines and formulas for fluid replacement in born patient. Concess formula, lactated Ringer solution or other balanced saline solution. 2 to 4 ml times kg body weight times percent total body surface area born have to be given in first 8 hours, remaining have to be given over next 16 hours. Evans formula: coilates 1 ml times kg body weight times percent TBSA bond. Electrolyte saline 1 ml times body weight times percent TBSA bond. Glucose 5% in water 2000 ml for insensible loss. Day 1 have to be given in first 8 hours, remaining half over next 16 hours. 2 half of previous days collates. Take 2 half of previous days coilots and electrolytes, all of insensible fluid replacement. Maximum of 10,000 ml over 24 hours. Second and third degree partial and full thickness bond exceeding 50% TBSA are calculated on the basis of 50% TBSA. Brook-Army formula collates 0.5 ml times kg body weight times percentage of TBSA bond. Electrolytes lactated Ringer solution 1.5 ml times kg body weight times percentage of TBSA bond. Glucose 5% in water 2000 ml for insensible loss. Day 1 have to be given in first 8 hours, remaining half over next 16 hours. Day 2 half of coilots, half of electrolyte, all of insensible fluid replacement. Second and third degree partial and full thickness bonds exceeding 50% TBSA are calculated on the basis of 50% TBSA. Parkland/Bastard formula: lactated Ringer solution 4 ml times kg body weight times percentage of TBSA bond. Day 1 have to be given in first 8 hours, have to be given to over next 16 hours. Day 2 varies, colloid is added. Hypertonic saline solution: concentrated solutions of sodium chloride NaCl and lactate with concentration of 250 to 300 MEq of sodium per liter, administered at a rate sufficient to maintain a desired volume of urinary output. Do not increase the infusion rate during the first 8 postborn hours. Serum sodium level must be monitored closely. Goal: increase serum sodium level and osmolality to reduce edema and prevent pulmonary complication. Acute or intermediate phase of born care. The acute or intermediate phase of born care follows the emergent resuscitative phase and begins 48 to 72 hours after the born injury. During this phase, attention is directed toward continued assessment and maintenance of respiratory and circulatory status, fluid and electrolyte balance, gastrointestinal function, infection prevention, burn wound, that is wound cleansing, topical antibacterial therapy, wound dressing, dressing changes, wound debridement and wound grafting, pain management, nutritional support. Assessing the urinary output. Insert a Foley catheter in patients with burns less than 15% TBSA. Adequate urine output is 0.5 ml per kg per hour in adults and 1.5 ml per kg per hour in children. Observe urine for burgundy color, seen with massive injuries or electrical burns. There is a high incidence of renal failure associated with these injuries, requiring prompt and aggressive intervention. Infection prevention. Despite aseptic precautions and the use of topical antimicrobial agents, the bondwood is excellent medium for bacterial growth and proliferation. Bacteria such as Staphylococcus, Proteus, and Pseudomonas, Escherichia coli, and Klebsiella find optimal conditions for growth within the bond wound. The bone eschar is a non-viable crust with no blood supply. Therefore, neither polymononuclear leukocytes or antibodies nor systemic antibiotics can reach the area. Phenomenal numbers of bacteria, more than 1 billion per gram of tissue, may appear and subsequently spread to the bloodstream or release their toxins, which reach distant sites. Staphylococci and enterococci are the organisms responsible for more than 50% of non-mere bloodstream infections in patients with burn injuries. Fungi such as Candida albicans also grow easily in burn wounds. When the burn wound is healing through spontaneous reepithelialization or is being prepared for skin grafting, it must be protected from sepsis. Burn wound sepsis has these characteristics: 105 bacteria per gram of tissue, inflammation, sludging and thrombosis of dermal blood vessels. The primary source of bacterial infection appears to be the patient's intestinal tract. The source of most microbes, the intestinal mucosa, normally serves as a barrier to keep the internal environment free from a variety of pathogens. After a severe burn injury, the intestinal mucosa barrier becomes markedly permeable. Because of this impaired intestinal mucosa barrier, the disturbed microbial flora and endotoxin forms in the intestinal lumen pass freely into the systemic circulation, finally causing infection. If the intestinal mucosa receives some types of protection against permeability change, infection could be avoided. Early anterior feeding is one step to help avoid this increased intestinal permeability and prevent early endotoxin translocation. Infection impedes burn wound healing by promoting excessive inflammation and damaging tissue. A major secondary source of pathogenic microbes is the environment. Infection control is a major role of the burn team in providing appropriate burn wound care. Cap, gown, mask, and gloves are worn while caring for the patients with open burn wounds. Clean technique is used when caring directly for burn wounds. Tissue specimens are obtained for culture regularly to monitor colonization of wound by microbial organisms. This may be swab surface or tissue biopsy cultures. Swab or surface cultures are non-invasive, simple, and painless. However, data obtained from such culture apply only to the area sampled. Therefore, invasive wound biopsy culture may be required. Antibiotics are seldom prescribed prophylactically because of the risk of promoting resistant strains of bacteria. Systemic antibiotics are administered when there is documentation of burn wound sepsis or other positive cultures such as urine, sputum, or blood. Sensitivity of the organisms to the prescribed antibiotics should be determined before administration. Several parenteral antimicrobial agents may be given together to treat the infection. Careful attention is paid to antibiotic use in the burn unit because inappropriate use of antibiotics significantly affects the microbial flora present in the unit. Wound cleaning. Various measures are used to clean the burn wound. Hydrotherapy in the forms of shower carts, individual showers, and bed baths can be used to clean the wounds. Total immersion of hydrotherapy is performed in some settings because of the high risk of infection and sepsis. The use of plastic liners and thorough decontamination of hydrotherapy equipment and wound care areas are necessary to prevent cross-contamination. Tap water alone can be used for burn wound cleansing. The temperature of the water is maintained at 37.8 degrees Celsius, 100 degrees Fahrenheit. And the temperature of the room should be maintained between 26 to 26.6 degrees Celsius and 29.4 degrees Celsius, 80 degrees to 85 degrees Fahrenheit. Hydrotherapy in whatever form should be limited to a 20 to 30 minute period to prevent chilling of the patient and additional metabolic stress. During the bath, the patient is encouraged to be as active as possible. Hydrotherapy provides an excellent opportunity for exercising the extremities and cleaning the entire body. When the patient is removed from the tub after the bath, any residue adhering to the blood is washed away. Any residue adhering to the body is washed away with a clear water spray or shower. Unburned areas, including the hair, must be washed regularly as well. At the time of wound cleaning, all the skin is inspected for any hints of redness, breakdown, or local infection. Hair in and around the burn area, except the eyebrows, should be clipped short. Intact blisters may be left, but the fluid should be aspirated with a needle and syringe and discarded. Conscientious management of burn wound is essential. When non-viable loose skin is removed, and certain condition must be established, wound cleaning is usually performed at least daily in wound areas that are not undergoing surgical intervention. When the eschar begins to separate from the viable tissue beneath, approximately 1.5 to 2 weeks after the burn, more frequent cleaning and debridement may be in order. After the burn wounds are cleaned, they are gently patted with towels and the prescribed method of wound care is performed. Physician preferences. The availability of skilled nursing staff and resources in terms of numbers of personnel, supplies, and time must be considered in choosing the best method for a given patient. Whatever the method, the goal is to protect the wound from overwhelming proliferation of pathogenic organisms and invasion of deeper tissues until either spontaneous healing or skin grafting can be achieved. Patient comfort and ability to participate in the prescribed treatment are also important considerations. Wound care procedures, particularly tube baths, are methodically stressful. Therefore, the patient is assessed for signs of chilling, fatigue, changes in hemodynamic status, and pain unrelieved by analgesic medications or relaxation techniques. Wound dressing. When the wound is clean, The burn areas are patted dry and the prescribed topical agent is applied. The wound is then covered with several layers of dressing. A light dressing is used over joint areas to allow for motion, unless the particular area has a graft and motion is contraindicated. A light dressing is also applied over areas for which a splint has been designed to conform to the body contour for proper positioning. Circumferential dressings should be applied distally to proximally. If the hand or foot is burned, the fingers and toes should be wrapped individually to promote adequate healing. Burns to the face may be left open to air once they have been cleaned and the topical agent has been applied. Careful attention must be given to burns left exposed to ensure that they do not dry out and convert to a deeper burn. Close communication and cooperation among the patients, surgeon, nurse, and other healthcare team members are essential for optimal burn wound care. Different wound areas on a given patient may require a variety of wound care techniques. Diagrams posted at the bedside are useful to inform staff of the current prescription for wound care, splints to be applied over dressings, and the exercise regimen to be followed before dressings are reapplied. Wound debridement. As debris accumulates on the wound surface, it can retard keratinocyte migration, thus delaying the epithelialization process. Debridement, another facet of burn wound care, has two goals: to remove tissue contaminated by bacteria and foreign bodies, thereby protecting the patient from invasion of bacteria; to remove the vitalized tissue or burn eschar in preparation for grafting and wound healing. There are three types of debridements: natural, mechanical, surgical. Natural debridement. The dead tissue separates from the underlying viable tissue spontaneously. After partial and full thickness burns, bacteria that are present at the surface of the burned tissues and the viable tissue underneath gradually liquefy the fibres of collagen that hold the eschar in place for the first or second post-bone week. Proteolytic and other natural enzymes cause this phenomenon using antibacterial topical agents. However, thanks to slow this natural process of eschar separation, it is advantageous to the patient to speed this process through other means, such as mechanical or surgical debridement, thereby reducing the time during which bacterial invasion and other iatrogenic problems may arise. Mechanical debridement. Mechanical debridement involves using surgical scissors and forceps to separate and remove the eschar. This technique may be performed by skilled physicians, nurses, or physical therapists, and is usually done with daily dressing changes and wound cleansing procedures. Debridement by this means is carried out to the point of pain and bleeding. Homeostatic agents or pressure can be used to stop bleeding from small vessels. Dressing are also useful debriding agents. Quas mash dressing. Apply dry or wet to dry. Apply wet and allow to dry. We slowly debride the wound of exudate and eschar when they are removed. Topical enzymatic debridement agents are available to promote debridement of the burn wounds. Because such agents do not have antimicrobial properties, they should be used with topical antibacterial therapy to protect the patient from the bacterial infection. Surgical debridements. Early surgical excision to remove the vitalized tissue along with early burn wound closure is now being recognized as one of the most important factors contributing to survival in the patients with major burn injury. Aggressive surgical wound closure has reduced the incidence of burn wound sepsis, thus improving survival rates. Early excision is carried out before the natural separation of eschar is allowed to occur. Surgical debridement is an operative procedure involving either primary excision, surgical removal of tissue of the full thickness of the skin down to the fascia, tangential excision, or shaving the burnt skin layers gradually down to freely bleeding viable tissue. Surgical excision is initiated early in burn wound management. This may be performed a few days after the burn or as soon as the patient is hemodynamically stable and edema has decreased. Ideally, the wound dissolving is then Ideally, the wound is then covered immediately with a skin graft if needed, and occlusive dressing. If the wound bed is not ready for a skin graft at the time of excision, a temporary biologic dressing may be used until a skin graft can be applied during subsequent surgery. The use of surgical excision carries with its risk and complication, especially with large burns. The procedure creates a high risk of extensive blood loss, as much as 100 to 125 ml of blood per percent body surface excised. Take two. As much as 100 to 125 ml of blood per percent body surface excised, and lengthening operating and anesthesia time. However, when conducted in a timely and efficient manner, surgical excision results in shorter hospital stays and possibly a decreased risk of complication from invasive burn wound sepsis. Grafting the burn wound. If wounds are deep, full thickness, or extensive, simultaneous repitalization is Check 2. If wounds are deep, full thickness, or extensive, spontaneous reepithelialization is not possible. Therefore, coverage of the burn wound is necessary until coverage with the graft of the patient's own skin antigraft is possible. The purpose of wound coverage are to decrease the risk for infection, prevent further loss of protein, fluid, and electrolytes to the wound. The minimize its loss through evaporation. Several methods of wound coverage are available. Some are temporary until grafting with permanent coverage is possible. Wound coverage may consist of biologic, biosynthetic, synthetic, and autologous methods or combination of these approaches. The main areas for skin grafting include the face for cosmetic and psychological reasons. Functional areas such as the hands and feet, and areas that involve joints. Grafting permits earlier functional ability and reduce contraction, shrinkage of bone scar through collagen maturation. When bones are very extensive, the chest and abdomen may be grafted on first to reduce the bone surface. Granulation tissue fills the space created by the wound, creates a barrier to bacteria, and serve as a bed for epithelial cell growth. Richly vascular granulation tissue is pink, firm, shiny, and free of exudates and debris. It should have a bacterial count of less than 100,000 per gram of tissue to optimize graft take. If the wound is not ready for skin grafting, the bone wound is excised and allowed to granulate. Once the wound is excised, and a wound covering is applied to keep the wound bed moist and promote the granulation process. Another promising dermal substitute is alloderm. It's processed dermis from human cadaver skin, which can be used as a dermal layer for skin graft. When a donor site, the area from which the skin is taken to provide a skin graft for another part of the body is harvested for an autologous skin graft. Both the epidermal and dermal layers of skin are removed from the donor site. Alloderm provides a permanent dermal layer replacement. Its use allows the burn surgeon to harvest a thinner skin graft consisting of epidermal layer only. Pain is inevitable. Take 2. The pain management. Pain is inevitable during recovery from any burn injury. Pain in the burn patient has been described as a tormenting consequence of burn injury and wound healing. Burn pain is thought to have both nociceptive and neuropathic pain components. Management of the often severe pain is one of the most difficult challenges facing the burn team. Many factors contribute to the burn patient's pain experience. These factors include but are not limited to the severity of the pain, the adequacy of the healthcare provider's assessment of the pain, the appropriateness and adequacy of the pharmacologic treatment of the pain, the multiple procedures involved in burn care, wound care, rehabilitative exercises, and appropriate evaluation of the effectiveness of pain relief measures. The outstanding features of burn pains are its intensity and long duration. Further necessary wound care carries with the anticipation of pain and anxiety. In partial thickness burns, the nerve endings are exposed, resulting in excruciating pain with exposure to air currents. Although nerve endings are destroyed in full thickness burns, the margins of the bone wounds are hypersensitive to pain, and there is pain in adjacent structure. Healing of full thickness bone creates significant discomfort as regenerating nerve endings become entrapped in scar formation. Most severe burns are a combination of partial thickness and full thickness burns. Both patients have been described as having three types of pain: background pain or resting pain, procedural pain, breakthrough pain. Background pain: it is the pain that exists on a 24-hour basis. Procedural pain: it's pain caused by procedures such as burn wound care or range of motion exercises. Breakthrough pain occurs when blood levels analgesic agents fall below the level required to control background pain. The patient's pain level must be assessed throughout the day because each type of pain is different, and various pain management strategies may be needed to address different types of pain. The primary pain from the burn itself is intense in the initial acute post-burn phase. In the next few weeks thereafter, until the skin heals or skin grafts are applied and heal, the pain intensity remains high because of treatment-induced pain. Wound cleaning, dressing changes, debridement, and physical therapy can all cause intense pain. Donor sites may be intensely painful for several days. Discomfort related to tissue healing, such as itching, tingling, and tightness of contracting skin and joints, adds to the duration, if not the intensity, of pain over weeks or months. Because pain cannot be eliminated short of complete anesthesia, the goal is to minimize the pain with analgesic agents to an acceptable goal set by the patient. Opioid administration via the intravenous routes, particularly in the emergent and the acute phase of burn management, remains the mainstay for pharmacologic management of burn pain. Use of opioids is complicated by the fluctuation in the availability of drugs, protein binding of the drugs, and the drug clearance related to the hemodynamic and fluid volume shifts that occur with a burn injury. Absorption of the opioid also may be affected. Titrating analgesic agents to obtain pain relief while minimizing side effects is crucial. The burn patient's requirements for analgesia are often high, but fear of addiction on the other part of patient and healthcare provider hamper adequate opioid administration. Morphine sulfate remains the analgesic of choice for treatment of acute burn pain. It is titrated to obtain pain relief based on the patient's self-report of pain using a standardized pain rating scale. Fentanyl is another useful opioid for burn pain, particularly procedural burn pain. It's also been shown to be effective for management of intense pain of short duration. Fentanyl has a rapid onset, high potency, and short duration, all of which make it effective for use with burn wound procedures. Appropriate cardiac and respiratory monitoring must be carried out during its administration. Patient control analgesia, in which a pump is used to administer a continuous infusion of an opioid, maintains a steady level of opioid for pain relief. Use of continuous infusion requires close monitoring of the patient's responses. Sustained release opioids such as MS-cotin or oxycodone, have also been used successfully in the treatment of burn pain. This medication can effectively treat the resting pain that is often associated with burn injury. Additional medications must be prescribed with this medication to cover breakthrough pain. Some burn units are used for administered nitrous oxide during burn wound procedures. Proper ventilation and monitoring equipment and availability of qualified personnel to administer nitrous oxide limits its use. Anxiety and pain go hand in hand for burn patients. The entire burn experience can produce severe anxiety, which can in turn exacerbate pain. Therefore, the ideal pain management regime must incorporate the treatment of pain and anxiety and must be individualized for each patient. Sedation with anxiolytic medications such as lorazepam, Ativan, and midazolam Vazad may be indicated in addition to the administration of opioids. The use of non-pharmacologic measures has also proven effective in the management of burn pain. These measures include relaxation techniques, deep breathing exercises, distraction, guided imagery, hypnosis, therapeutic touch, humor, information giving, and music therapy. Music therapy has gained interest recently in the treatment of pain. Researchers have found that music affects both the physiologic and psychological aspects of the pain experience. Music diverts the patient's attention from the painful stimulus, provides reality orientation, distraction, and sensory stimulation, and allows for patient self-expression. Nutrition supports. Burn injuries produce profound metabolic abnormalities followed by the Burn injuries produce profound metabolic abnormalities followed by the exaggerated stress response to the injury. The body's response has been classified as hyperdynamic, hypermetabolic, and hypercatabolic. Hypermetabolic can affect mobility and mortality by increasing the risk of infection and showing the healing rates. Patients' metabolic demand vary with the extent of the burn injury. Hypermetabolic is evident immediately after a burn injury. The degree of the response depends on the size of the burn and the patient's age, body composition, size, and genetic response to insults. Persistent hypermetabolism may last up to 1 year after burn injury. Major metabolic abnormalities seen after a burn injury include increased catabolic hormone, a decreased anabolic hormones, human growth factor, and testosterone, a marked increase in the metabolic rate, a sustained increase in body temperature, a marked increase in glucose demands, rapid skeletal muscle breakdown with amino acids serving as the energy source, lack of ketosis, indicating that fat is not a major source of calories, and catabolism that does not respond to nutrient intake. Therefore, it is essential to control the stress response by increasing the anabolic process through adequate nutrition and increased muscle activity, decreasing heat loss from wounds, and maintaining a warm environment. Controlling secondary stress such as pain and anxiety also help to control the stress response. The most important of this intervention is to provide adequate nutrition and calories to decrease catabolism. Nutritional support with optimized protein intake can decrease protein losses by approximately 50%. Healing of the burn wound consumes large quantities of energy. Effective nutrition management depends on how well the energy expenditure due to the burn injury can be estimated and matched with appropriate amounts of micronutrients, carbohydrates, lipids, and protein. The goal of nutritional support is to promote a state of positive nitrogen balance by optimizing nutrition to match nutrient utilization. The nutritional support required is based on the patient's pre-burn status and the TBSA burn. Several formulas exist for estimating the daily metabolic expenditure and caloric requirements of patients with burn injuries. The most common used formulas include the Curie formula, which uses body weight and percent burn, and a variation of the Harris-Benedict equation, which determines basal energy requirements based on stress and bone size. Protein requirements may range from 1 to 5 to 4.0 gram of protein per kilogram of body weight every 24 hours. Lipids are included in the nutritional support of every bone patient because of their importance for wound healing, cellular integrity, and absorption of fat-soluble vitamins. Carbohydrates are included to meet caloric requirements as high as 5,000 calories per day and to spare protein, which is essential for wound healing. The patients also need adequate vitamins and minerals. Existing formulas may underestimate the daily metabolic expenditure associated with burns. The formulas fail to account for added stressors such as pain, anxiety, daily dressing changes, and decreased activity levels. This must be considered when estimating appropriate nutritional support. Research findings have brought about changes in specific guidelines for estimating energy expenditure during the various phases of post-burn recovery. The proportions of fat, protein, and carbohydrates must be carefully planned for maximum use. The internal route of feeding is far superior to the peripheral route. Enteric feeding preserves the intestinal barrier function and absorption of peptides. Absorption of peptides and amino acids, which leads to iron nitrogen retention. Feedings are started as soon as possible. If a feeding tube is used, placement into the duodenum is ideal to prevent aspiration and to allow for continuous, uninterrupted feedings. During surgical procedures, if the oral route is used, high protein, high calorie meats as supplements are given. Dietary consultations are useful in helping patients meeting their nutritional needs. Daily calorie counts aid in assessing the adequacy of nutritional intake. Overfeeding must be avoided because it increases metabolism, O2 consumption, and CO2 production. Patients lose a great deal of weight during recovery from severe burns. Reserved fat deposits are catabolized fluids. Reserved fat deposits are catabolized, fluids are lost, and calorie intake may be limited. Because a burn injury lowers the patient's resistance to infection and disease, the nutritional status may be improved and maintained, although the patient has a poor appetite and is weak. Rehabilitation phase of burn care. Rehabilitation begins immediately after the burn has occurred, as early as the emergent period, and often extends for years after injury. In the aftermath of the acute stage of injury, the burn patient increasingly focuses on the alterations in self-image and lifestyle that may occur. Wound healing, psychosocial support, and restoring maximum functional activity remain priorities. The focus on maintaining fluid and electrolyte balance and improving nutritional status continues. Reconstructive surgery to improve body appearance and function may be needed. Burn injuries can have a major impact on quality of life. Changes in physical activities and social, psychological, and employment status may occur. Therefore, psychological and vocational counseling and referral to support group may be helpful to promote recovery and quality of life. Family members also need support and guidance in assisting the patient to return to optimum health. Prevention of hypertrophic scarring. The wound is in a dynamic state for 1.5 to 2 years after the burn occurs. If appropriate measures are instituted during this active period, the scar tissue loses its redness and softens. Healed areas that are prone to hypertrophic scarring require the patient to wear a prayer garment. These devices are especially useful for partial thickness wounds that require more than 2 weeks to heal and for the edges of grafted skin. Applying elastic pressure garments loosens collagen bundles and encourages parallel orientation of the collagen to the skin surface with the disappearance of the dermal nodules. As pressure continues over time, there is a restructuring of the collagen and a decrease in vascularity and cellularity. The physical therapist, occupational therapist, or a representative of the manufacturer of elastic pressure garments measures the patient for correct fit. While awaiting the arrival of the garment, soft tubular knitted elastic pressure bandages can be used to help desensitize the patient's skin, protect from healing. Take 2. Help desensitize the patient's skin, protect healing areas, apply pressure, and promote venous return. Patients must be instructed about the need for lubrication and protection of the healing skin and the need for pressure garments for at least a year after the injury. A program including elastic pressure garments, splints, and exercise under the supervision of an experienced physical and occupational therapy team is recommended for optimal functional and cosmetic results. Nursing management. Airway management. Treatment of inhalation injury includes administration of 100% humidified oxygen are needed. Place the patient in the high Fowler's position unless contraindicated, e.g. spinal injury, and encourage coughing and deep breathing every hour. Reposition the patient every 1 to 2 hours to provide chest physiotherapy and suctioning as necessary. If respiratory failure develops, intubation and mechanical ventilation are initiated and the nurse assists as required. Fluid therapy. Establishing an intravenous access is critical for fluid resuscitation and drug administration. The extent of the burn wound is assessed using a standardized chart. This allows for the accurate estimation of fluid resuscitation requirements. The type of fluid replacement is determined by the size and depth of burns, age of the patient, and individual considerations such as pre-existing chronic illness. The Parkland-Baxter formula for fluid replacement is the most common formula used, followed by modified Brook formula. Take 2. Modified Brook formula. The nurse should ensure that the calculated amounts are delivered to the patients accordingly. Wound care. Once adequate circulation and adequate fluid replacement have been established, priority is given to care of the burn wound. Wound cleansing and gentle debridement using scissors and forceps can occur in cat shower. A once daily shower and dressing change in the morning, followed by a dressing change in the patient's room in the evening, is a common routine in many burn centers. Some of the newer antimicrobial dressing can be left in place from 3 to 14 days, thereby decreasing the frequency of dressing changes. Infection is the most serious threat to further tissue injury and possible sepsis, and hence treat asepsis should be maintained during dressing changes. Nutrition therapy. Early and aggressive nutritional support within several hours of the burn injury can decrease mortality risk and complications, optimize healing of burn wound, and minimize the negative effects of hypermetabolism and catabolism. Early enteral feedings, usually with small bowel tubes, preserve gastrointestinal function, increases intestinal blood flow, and promotes optimal condition for wound healing. Bowel sounds should be assessed every 8 hours. High protein, high calorie, and supplemental vitamins are given to aid wound healing and provide energy. Pain management. One of the critical functions of the nurse is to perform an ongoing pain assessment and management. Burn patients experience 2 kinds of pain: continuous background pain that may be present throughout the day and night, and treatment-induced pain associated with dressing changes, ambulation, and rehabilitation activities. This first line of treatment is pharmacologic, A continuous intravenous infusion of an opioid will allow for a steady therapeutic level of medication. Around the clock, oral analgesic can also be used. Breakthrough doses of pain medication need to be available regardless of the regimen selected. Anxiolytics, which frequently potentiate analgesic, are also indicated and include lorazepam and midazolam. Take 2. Midazolam. Pain can also be managed using non-pharmacologic strategies such as guided imagery, hypnosis, biofeedback, music therapy. Physical and occupational therapy. Physical and therapy throughout burn recovery is imperative to maintain muscle strength and optimal joint function. A good time for exercise is during and after wound cleansing, when the skin is softer and bulky dressing are removed. Passive and active range of motion exercise should be performed on all joints. The patient with neck bones The patient with neck bones must sleep without pillows or with the head angling slightly over the top of the mattress to encourage hyperextension. Psychosocial support. The nurse should provide support and counseling to the patients and caregivers. Pastoral care may also be appropriate for some patients and their caregivers. Complications of severe burn injury. Levels et al. 2007 identified two major complications of burn injury, which are hypertrophic scarring, keloid formation, skin and joint contraction. Other complications identified by Smerza et al. 2008 result from inability to prevent the major complications, and they include the following: neuropathies, peripheral neuropathies, mononeuropathies, multimononeuropathies, and nerve entrapment, which is caused by electrical injury, large deep burns, improper positioning, edema, scar tissue. Heterotropic ossification, abnormal function of bones in response to soft tissue trauma caused by prolonged immobility. Wound breakdown caused by shearing, pressure, and inadequate nutrition. Gut deviations caused by pain, burn wound, donor sites, scarring of joints, electrical injury of the brain. Complex regional pain syndrome. Previously reflex sympathetic. Complex regional pain syndrome. Previously reflex sympathetic dystrophy caused by trauma and burns. Joint instability caused by burn wound, burn scar, and contractures. Study section summary. In this study section, severe burns, which is very devastating condition, is the breakdown in skin continuity, which can be due to thermal, chemical, or electrical causes. It can be classified based on its depth, extent of total body surface area burn, location, and patient risk factor. Is a condition with multi-systemic effects. Severe burn injury is one of those conditions that place the patient at risk due to its multi-systemic effects. The management of severe burn injury is in three phases, which are the emergent, resuscitative, acute, and rehabilitative phases, respectively, and it includes pre-hospital care and emergency room care, and begins at the time of injury till the restoration of capillary permeability. Usually 40 to 78 hours following burn injury. The aim of management at this phase is to prevent hypovolemic shock by maintaining adequate circulating blood volume and preserve vital organ functioning. The resuscitative phase begins with the initiation of fluids until capillary integrity returns to normal level. Administration of fluid is based on the body weight and extent of injury, and the formulas are calculated from the time of injury and not from the time of arrival at the hospital. Management of this. It is important that individuals avoid unsafe practices that could predispose them to burn injuries, and education about ways of burn prevention be made available. Take 2. Education about ways of burn prevention be made available to people, especially in the dry seasons and during petrol scarcity in our locality. Conclusively, as healthcare practitioners, we are expected to equip ourselves with the knowledge of the causes, types, classification, and management of burn injury, so as to be able to identify risk factors and severity in order to provide effective management for the patients and prevent complications. We've come to the end of study section 5. Thank you for listening. Thank you for listening.